have a selection of 2 probes on this machine. At Prince George's we have 3 probes on the machine. And once you decide which probe you want to use, you can set up the machine to send the image from that probe to the processors. So this is the vascular linear probe. It's a high frequency probe, which means that it doesn't get too far into the tissues, but it gives you a very nice high resolution picture for the superficial structures. So needle procedures, soft tissue ultrasound, looking at tendons, for abscesses, this is your probe. This is our all-purpose workhorse. It's lower frequency, gets deeper into the tissues, so using this for transabdominal pelvic ultrasound, looking for the abdominal aorta, looking at the heart. This is the abdominal and cardiac probe that we use. And so there are 3 buttons down here. We have 2 probes currently hooked up. And in order to select the vascular probe, you just follow the cord back to the blue button and push the blue button. It gives you the vascular footprint here. And for the cardiac abdominal probe, again, you just push the button connected to it, and it changes the ultrasound machine over to look at the other probe.
Today, I'm going to show you guys how to hold the probe and how to orient the probe when you do an ultrasound exam. Here's a linear probe, typical linear probe. If you look around the probe, there's a lot of kind of knobs and marks. The way you hold a probe in general is like a pencil, and you want your fingers very close to the footprint, and that allows you to manipulate the probe with very fine movement. So you typically anchor the probe on the patient's skin, and you want to have some part of your body touching the patient. That's because there's going to be jelly between your probe and the patient's skin, and if you don't anchor your hand or fingers on the patient, then the probe is easy to slide around without you meaning to move the probe. All right. Now, looking at this knob, all right, this in general corresponds to the probe marker right here. And that tells you which way is up and which way is right or left. If you use an ultrasound gel and just put the jelly on one side of the probe, that's the foolproof way to figure out whether this side corresponds to the screen's left or right, because you can see that the gel side is the left side. Or you can touch it and you'll realize that that's the side that corresponds to the left side. Okay? The way for diagnostic ultrasound to work, in order for the picture to appear like a CAT scan image, we always have the probe marker to the patient's right for a cross-section image, or to the patient's head for a sagittal image, except for the cardiac exam, and then we'll talk about that during the rotation. For procedural guidance, it's no longer about the patient, and it's about the operator. So it doesn't matter whether you're at the head of the patient, of the bed, or at the foot of the bed, whether you're right-handed or left-handed. You keep the probe marker to your left hand. This way, if the target is to the left side of the screen, your needle needs to go toward the left. You keep everything in line, right? And that's how you hold the probe. Go.
One other part, when you're ultrasounding patients, at some point you want to document what you did. And so underneath every machine in the George Washington system, we have one of these ultrasound logbooks. This is the one from our Fast Track machine here. If we open it up, you'll find a bunch of these sheets. They have different areas to enter data. You can enter some of the data before you go in the patient's room, afterwards, whatever works for you. But just make sure that you enter data. It seems like, oh, here's one actually that myself and Keith did just the other day. This is on a Mr. John Doe. You can see we hand wrote his name in, his medical record number, the date, and our names here. You could easily put the patient sticker here if you get a hold of it and it's much easier for you. Whichever your preference, that's fine. You could do some of this entry before you do the ultrasound, or you could do it all afterwards, no problem. After you've entered this information, you'll see that on Mr. John Doe, we performed an obstetric ultrasound. Interestingly, he did have vaginal bleeding and pelvic pain, so we did a transvag ultrasound. And thankfully, we did not identify any intrauterine pregnancy, but we did find some free fluid. Now, given that Keith and I are experienced sonographers, we were debating whether or not to get any confirmatory study, but in this case we did. He was sent over to radiology to have a confirmatory transvaginal ultrasound. Thankfully, they identified the exact same findings we did. In your case, if you don't have any confirmatory study, it's okay to write none or and not applicable, or if, for example, you ultrasounded an abscess and then you proceeded to incise it, you could write that and note that pus was obtained, or whatever confirmation you have. Regardless, this documentation is essential, and so I would budget some time at the end of your scan shift to go and review all the scans you did and make sure that if a CT was pending at the time that you did the scan, maybe you can get the result before the end of your shift and write that in here. Not only is that helpful for your education, but when we as the ultrasound team and you as a person rotating with us go through and do scan review every Monday morning, we have a lot of information to work off, make sure that the patients are well cared for, and improve our teaching and learning.